Yes, thank you for the introduction. Some great talks today, beautiful background, and as I say, as has been mentioned, you already heard from Henk earlier, who is working in the same institute and gave a bit of an introduction. I have a more beautiful picture. The laboratories are based in the concrete building that Henk showed. So. What I would like to talk about is disruptive developments in tuberculosis diagnostics and what implications this has for where we go forward and what we think about. So 10 years ago, things were quite simple in a way, at least they were quite clear. We had microscopy and we had culture. And if you were adventurous, sophisticated, or had lots of money, you were doing some molecular activities. And importantly, the follow-up was using the similar technologies. So we were following up with microscopy and culture conversion or susceptibility testing. And as you know, TB is the treatment for tuberculosis is relatively long and complicated. So it's 6 months of treatment. So this issue of getting the right people on treatment and keeping them on treatment and making sure the treatment's working is very important. The diagnostics of TB, although there have been huge advances and there are many stakeholders who've done the work, it's still there is still not this simple test available, and there are some very creative people working on this. But I mean, in the immediate future, I think it's safe to assume that simple dipstick test is going to be some financial and time distance away from us. And as I've already mentioned, the treatment of tuberculosis is complicated, and you want to get it right. Culturing of TB is difficult for everybody. The point of care PCRs have been amazing and really started to transform tuberculosis diagnostics. And I mean, this paper from the Lancet by Grant Theron was very interesting study of the effect of these tests, so the rollout and what we can learn from this. So we do indeed get more patients starting same-day treatment, but this did not translate into lower tuberculosis-related morbidity. And this is partly because physicians are not stupid. They can recognize tuberculosis, and they were starting people on therapy who were smear negative. These are interesting discussions to have, of course, because we don't absolutely know for sure whether those people without bacteriological evidence of treatment had disease or not. And if you overtreat a, quote, healthy population, your morbidity will be less. So there are important considerations between the morbidity in your patient population, your identified patient population, and the total population. So it is possible that these more precise tests will have a population effect which is not seen in the cohort. Just as if you want good outcomes for your cancer treatment, you better not treat people who've got cancer, and then none of them will die of cancer. Yes, this was my slide to say that. But this is an important consideration, but this is something which also calls for following up the effect. And that's what the patient cares about. Of course, the patient, well, it's nice to have a diagnosis, it's nice to know what's wrong with you. It's even better if that's the correct diagnosis. And it's even better if the drugs are going to work and they're going to help your disease. So what I'm making a case for, and it was mentioned in the first talk today, is monitoring of therapy is important, and particularly important in tuberculosis. And the incredible developments in diagnostics in the past 10 years are exposing a weakness in this. So other people have obviously realized this, and these publications are great from the point of view of it was already mentioned today that the diagnostic community is quite responsive or has been responsive to calls and requirements, identifications of characteristics, and the specifications generated with the support of FIND are very useful. And here you see treatment monitoring is moving up the list. So I'd like to talk. Our group has interest in microscopy, has an interest in culture. As Henk mentioned, we've been working on multiplex molecular assays, but I'm not going to talk about that today. I'm going to concentrate on this relatively pragmatic approach, but it's something which I think can have an impact and can be very valuable. So we are now calling this MOTET, monitoring of the effect of tuberculosis treatment, and MOTET is some nice ancient form of music if you want to listen to it. And this idea was published some time ago by a postdoc in my group, Elise Den Hertog, and this paper is quoted in the booklet that goes with this meeting. So the MOTET concept is to measure the patient's response to early bacterial killing. So we can detect that the patient is on appropriate treatment. And this is nice in tuberculosis because we can follow host markers which are not necessarily in and of themselves specific for tuberculosis, but if we perform an intervention, if we start treatment, and these markers respond, the kinetics of these markers respond in the way that we know is associated with effective treatment, we are adding specificity for that marker to confirm the response and the diagnosis. So we can detect patients who are responding to therapy. So we can, if they're responding to therapy, they're on the correct treatment. If they're not responding to therapy, there are various reasons for that. They could have been misdiagnosed. They could be infected with a strain of tuberculosis which is not sensitive to the drugs they're taking, or there could be a problem with the drugs. They're not taking the drugs because they're not taking the drugs, or they're not taking the drugs because the thing they are taking doesn't contain any active drug. It's fake or something like that. So this is quite a powerful thing to be able to do. So this idea was very nice. We have some markers, and we wanted to check in a placebo control or infection control trial. So we want to be able to start animals on treatment who are not infected and look at the response of these markers. And this was done. This was funded by TI Pharma, a funding agency, and the results were very nice. We also used this model to look at the speed of these results, and we saw that the kinetics were pretty good. We are seeing a response in 3 days, a clear response after 7 days, very nice kinetics and stable kinetics. So we believe what is going on. So we were quite excited about this. We spoke to our colleagues. We spoke to Louis Cuevas, who is also in the audience in the Liverpool School, and he managed to put us into contact with Nepal and Nigeria, and together we did a study on the kinetics to replicate the mouse data in real human samples. And just this lunchtime, I heard that this paper has been accepted and will be online shortly. So basically, we looked at the kinetics of our host immunomarkers in all patients who started treatment, regardless of whether that was a diagnosis by microscopy, gene expert, or clinical suspicion. we collected the serum samples, and very nice that the previous talk from the Merck, we use ELISA to read these cytokines, and there are some very exciting developments in simplifying, in producing also handheld near-patient devices to read ELISA results. And then the responses we see were correlated, obviously, with the diagnostic smear culture and DST results. So these are some ROC curves, and these are ROC curves not of sensitivity and specificity. This is not a diagnostic test. These are ROC curves for the markers to call a patient who is on appropriate treatment, who is responding to the therapy. And this marker comes out every time. This marker comes out in many studies, and the kinetics of this marker we've demonstrated are really quite rapid. And this is IP10, and this is a specificity sensitivity. So we can select a delta at between 0 and 7 days, so a shift in IP10 levels, an absolute shift in IP10 levels, which gives us a very good call of patients who are on appropriate therapy and responding to therapy. Everything is going well. Keep doing what you're doing. Everything is okay. But we can flag up a group of patients who need more intensive diagnostic workup. There's something not right. Either the drugs there's resistance, so the drugs are not working. The diagnosis was incorrect. And this is in the first week of therapy, as opposed to if you were monitoring with culture or microscopy conversion in the original, in the recommendation. So that would be 2 or 3 months down the line before you realize something's going on. So we think this is, very interesting way of looking at it, and could have an impact. And so this is a breakdown of the results per patient. Each line is one patient. So we have HIV positive, smear positive, culture positives, and these are the IP10 levels. IP10 is generally higher in HIV positive patients. That's been confirmed with other groups. So the sensitivity of this biomarker is probably going to be high, is even better in this group. This dashed line is very interesting. It's a one-tube experiment, but it's tantalizing. This patient was subsequently confirmed to be infected by MDR tuberculosis, so that's nice. So then we have HIV positive, smear positive, culture positives. Again, the same trend. HIV positive, smear negatives, culture positives. The interesting thing is, on this limited data, we are going forward now with some larger studies and trying to get funding for some larger studies. The smear positivity doesn't appear to have a dramatic effect on the performance. We have HIV negative, smear negative, culture positives, and again, you're getting similar results. And this is a very interesting group, of course. These are people who were smear negative, culture negative, and this group of patients were started on therapy because of a clinical suspicion of tuberculosis. So it's not clear. Of course, there is possibility that some of the people in this group actually didn't have tuberculosis. Of course, we have no evidence that they had tuberculosis. So what now? So we think this is potentially highly informative and deserves to be carefully studied. We also think it's important that this is an ELISA assay. The levels are quite high. It's quite a good marker to measure, and we are in discussions with various large companies and groups about how this might be turned into a rapid near patient assay, and we think this is entirely realistic, and what we've heard today would maybe support that. Of course, it's not a new idea. I'm not telling you anything fantastically amazing conceptually, but it's the way of thinking of how we could use this and what impact this can really have on getting the right therapy to the right patients and getting these patients cured. So clinical history is a similar idea. I mean, obviously, these immunomarkers are associated with fever, they're associated with symptoms, they're associated with night sweats. And when you can afford if you can afford to measure the patient, and this has been looked at, and this is known to be informative. And I mean, people have in the literature, of course, looked at it in a more structured way. Here there's a paper from 1995 also saying people with prolonged fever who are not recovering may be an appropriate subgroup for targeted broader empirical therapy. So I mean, this idea is out there. I do think that the wearable technologies and things are very interesting from this perspective. We have the perspective of really in the next generation of these technical devices having ambulatory data from large numbers of people and directly uploaded to the cloud and relatively cheaply available. And I was hearing that there are even people working on systems for pseudo non-invasive continuous monitoring of immunomarkers in a sort of wristband or something, or a plaster. So this can be very interesting. One thing we can do at the moment is we can measure temperature. There are temperature monitors available. You can wear these for a few days. You can stick these to yourself, and this sort of physiological data probably has a lot of information, more information than a nurse taking your temperature 4 times today. And for monitoring the recovery, the physiological status of patients, I think this is something which maybe will explode in the next 10 years. So we think that there's potential for our immunomarkers to be measured very simply, very cost effectively by a healthcare worker visiting with a handheld device. And this could be an extremely valuable addition to the control of tuberculosis. And of course, we need to expand our patient cohort, but we're working on that, and we think it's very exciting at this moment. So this would be our visual representation of what we do at the moment. Of course, we have these now highly sensitive devices which can detect tuberculosis, but we're still following up with culture and microscopy at 2 and 3 months. These PCRs, at least in their current format, are not at all suitable for the monitoring of therapy. Whereas if we can identify some easily measured host-derived markers, which are present in known concentrations, present in all patients, which will give us a much or even equivalent handle on this after 1 week instead of 3 months, this can be very valuable, clinically useful information. And that's what the person who's infected with TB cares about. They want to know, will the drugs work? Are the drugs working? And susceptibility testing, even susceptibility testing on its own, is not enough. You have other issues, and DST testing is looking at the bacteria, which is very important, but it's not the whole story. This is also recently, I think in this month's International German Journal of Tuberculosis Lung Disease from David Dowdy's group, the possibility for relapse and a test of cure. And looking at I'm not claiming we've got a test of cure yet. We don't know that. We've looked at early time points. But these markers of how the disease is progressing have also the potential to monitor people at the end of treatment and post-treatment. And as was pointed out here, this is a very important group of patients who finish tuberculosis treatment, because they are at 20,000 times higher than the targeted risk for tuberculosis. So they deserve some attention. So there were lots of people involved in this work in small and larger projects. The TB group in Kit Biomedical Research has been extremely useful for me to bounce ideas off. So I'd like to say thank you to all my scientific collaborators, and of course thank you to the patients who gave us their serum samples to test, and we hope we can get some useful and valuable and helpful assays out of that. Thank you very much.